Hi there everyone, and welcome to our first session of our data interpretation crash course. Today we will be going through how to interpret an ECG so that you guys will be ready for your OSCE exams at the end of the year if they are to take place. And we have Lily, who is a final year medical student from Imperial College, who has kindly given up her time to give us this tutorial. So I'll hand over to Lily now, if you'd like to quickly introduce yourself.
Yeah, sure. So hi everyone, my name is Lily. I'm a final year medical student, as Chan has said. So yeah, today we're going to mainly focus on a rough introduction to ECG. I think we'll start the tutorial then. So, one second. Yeah, so I've got some learning objectives just so we know what to get out of this tutorial. So essentially, by the end of the tutorial, I want us all to be able to present a 12-lead ECG, understand some of the electrophysiology of an ECG trace, and understand what composes of a normal ECG, and be able to recognize some of the common arrhythmia patterns that you might be presented with at the end of your cardio station in OSCE. And yeah, just as a heads up, that the tutorial is not for comprehensive management, that we will for the ECG abnormalities, but I will just talk through briefly about the conditions that we will see in the presentation that I've prepared. Okay, so to be able to understand ECG, you need to first go through the sequence of a cardiac cycle. I'm sure this is very basic, but we'll just recap it. Essentially, your SA node in the right atrium is your heart's natural pacemaker. And so if you remember back to year one, the funny current starts off the whole electrical current in the whole cardiac cycle, and that travels to your AV node. And the AV node delays the electrical current by about 0.1 second before it travels down the bundle of His and the Purkinje fibers and causes the ventricular contraction. And then the whole thing goes to rest again and starts over again. So that's your whole cardiac cycle. And we can relate this cycle to a normal ECG trace. So as shown here, you've got your P wave, PR interval, QRS complex, ST segment, and T waves. So this is a basic unit of a essentially cardiac contraction, and your P wave is related to your atrial depolarization, and this is also when your atria contract. And then the PR segment essentially is the delay at the AV node, and this is followed by QRS, which corresponds to ventricular depolarization, and that's when your ventricles contract to create your cardiac output. And then finally you have your T wave, which is ventricular repolarization, so that gets ready for the whole thing to repeat itself once again. Yeah, so I've just listed the basic component of how to present an ECG. This is just something that you have to remember. So anything in clinical medicine is very important that you present the patient details first, and also it's important to know the date and time of when an ECG is taken. Because if you want to present an ECG from 2 years ago, it might not be so relevant to what's going on today. And then the rest of it is basically what information you can get from a 12-lead ECG. This includes rate and rhythm, cardiac axis, P wave, PR interval, QRS, ST, and QT interval. So I should have put T wave on there as well, which goes between ST segment and QT interval. In the rest of the tutorial, we're going to go through everything from rate to rhythm to QT interval. And an important thing is during your OSCE, you need to be able not to just understand a 12-lead ECG, you have to be able to present it. as well. And there's just a couple of things I want to say about that. So remember, I don't know if anyone has told you this, but OSCE exam in third year is essentially a tick box exercise. You don't have to be correct at all, but it's important that you know what constitute an ECG, and you have to essentially mention every component to be able for the examiner to tick the box for you on the mark sheet and for you to gain that mark. So it's brilliant if you can spot the diagnosis, but to get the highest possible mark, you can't just say what the diagnosis is and not present the rest of the ECG. You have to talk about every component. So I've just got a rough structure in the rest of this slide for you. So essentially, always start off by presenting the patient details. So in example here, you can see this is a 12-lead ECG of a 60-year-old gentleman, which was taken at this time and on this date. And sometimes you can also add in a little sentence for what's the indication. So why was the ECG taken? So in the example here, it was taken because the patient is experiencing crushing central chest pain. So next, I think this just makes people focus on the obvious abnormality, because sometimes the abnormality can be just sticking out quite a lot, and it might be a little bit silly to leave the obvious abnormality at the end of the presentation because you want to draw people's attention. So if you can spot it straight away, then say the obvious abnormality in this ECG is whatever you've spotted. And after this, you need to go back to every component that we've talked about on the slide before to be able to gain full mark in your essentially ECG Viva station. So you have to comment on the heart rate, you have to comment on the rhythm, the cardiac axis, and then go through each component of that cardiac trace that we talked about. Okay, so now I'm just gonna go through how to interpret each of the component that was already listed on the slides before we go through some example ones. So how to determine rate. So do all of you know the equation about the 300 divided by the number of large squares between the R to R interval to work out the rate? Just write yes or no in the chat for me if you can. Okay, cool. Seems like a lot of people have answered yes. So essentially, yeah, so there's a caveat. The only situation where you can use this is when you know that the ECG is in sinus rhythm. So it's in a regular sinus rhythm. We'll talk about how you calculate irregular rhythms in a bit, but essentially why the equation works is because the way the ECG is calibrated, the paper goes at a speed about 25 millimeters per second. So in a whole minute, it means it will go, the distance it traveled will be 1,500 millimeters. And because each little square is about 1 millimeter, therefore a large square is 5 millimeter. So if you divide by that, it means in 1 minute, the ECG paper would have traveled 300 large squares. And if the rhythm is regular and is also in sinus rhythm, you can just divide by the number of large squares between the R to R interval to work out the heart rate. However, if you have a rhythm that's irregular, or so you can have irregular rhythm where you don't see any P waves before the QRS. However, you can also have a irregular sinus rhythm where you see a P wave before the QRS. In those situations, you can't use this method because the intervals will be irregular. So in this case, how you would do it is normally at the bottom of the ECG, there's a rhythm strip. Usually the second wave is taken as the rhythm strip because P wave is usually best visualized on there. And in a normal like ECG page, it's 10 seconds. So you count every QRS in that whole ECG lead and times it by 6. So that's how you would work out if the heart rate in an irregular or irregular sinus rhythm ECG. And then now we go on to the rhythm. So as I already touched upon that, so you can have 3 types of rhythms. You can have regular sinus rhythm, regularly irregular sinus rhythm, and irregularly irregular rhythm. So regular sinus rhythm is very easy to understand, just means QRS follows every P wave, and the P wave to P wave interval are regular. And in regularly irregular sinus rhythm, so you still have the P wave present before every QRS, but P to P intervals are unequal. So essentially that just means your SA node are discharging at an irregular rhythm. And this can normally happen after you've had a myocardial infarction or any sort of ischemia that makes essentially the SA node to malfunction. But however, this rhythm is not quite common, but what is commonly seen is irregularly irregular rhythm. So this is when the P wave is not discernible under ECG at all, and normally this rhythm is synonymous with your atrial fibrillation. Okay, does anyone have any questions on that at all? Okay, so I'm gonna take that as a no, and then let's continue to cardiac axis. So I think cardiac axis can be a difficult one for a lot of people. I remember it being quite difficult for me. Essentially, you've got this pie chart, and essentially the direction of the vector is shown with each lead. The label of each lead is essentially overlying the direction of that vector. And I'll come back to this diagram in a bit, but essentially I'm gonna just teach you a very easy way of determining the cardiac axis. It'll only take about, I think, less than 5 seconds if you know this method. So essentially what you need to look at really is just lead 1 and AVF. So if you have normal axis, you would have a positive depolarization in both lead 1 and AVF. However, with right axis deviation, you would have a negative depolarization in lead 1. So essentially when you look at them, the peaks are facing towards each other. And with left axis deviation, you have a negative depolarization in lead AVF. Essentially on ECG, the peaks are facing away from each other. And just to illustrate how this works, so if we go back, if we take normal axis as an example, and we go back to this diagram, I don't know if you can see my cursor, but so with lead 1, any direction from minus 90 degrees to positive, so plus 90 degrees, will produce a positive deflection in the direction of lead 1. And if any, so AVF is here, so any direction from 0 degrees to 180 degrees will produce a positive deflection in the direction of AVF. So the 2 overlapping area would be 0 to 90 degrees. And if you compare it to this pie chart, the overlapping degrees is exactly overlying the normal QRS axis. So essentially that's how it works. But if you can't bother to learn the actual mechanism, just remember this table, and hopefully you'll be able to find working out the cardiac axis a lot easier. Okay, so next we go on to, yeah, so someone just asked me how it works again. That's fine. So there's this pie chart. So the lead 1 is in this direction towards at 0 degrees. Anything in minus 90 to plus 90 degree. So if lead 1 has a electrical current in the direction of minus 90 to plus 90, this is the half of the circle towards the lead 1 area that will produce a positive deflection in the direction of lead 1. Okay, and in AVF, that would change to from 0 degrees to 180 degrees. So anywhere in the bottom half of the circle will produce a positive deflection. So when you overlap the two areas together with the positive deflection in lead 1 and the area in AVF, you have an overlapping area of 0 degrees to 90 degrees. And that will tell you, the overlapping area tells you where the cardiac axis is likely to lie. All right, okay, cool, that makes sense now. All right, so if we move on, so with your PR, QS, and QT interval, so you really just need to remember the normal range for them. And essentially, I've given you the normal range here. You can either remember it in seconds or the number of small squares. So this will come on relevant in the cases that I'm going to show you for the rest of the tutorial, for the rest of this tutorial. But yeah, essentially this is just something for you to remember. And I'm just gonna like touch on a few things. So with QRX, if it's normal, essentially 2 to 2.5 squares, we normally describe it as narrow complex. So in your presentation, if it's normal, you would say QRX complex is narrow. However, when it's abnormal, it's usually wide. So it would usually be larger than 2.5 small squares. Then you would describe it as QRS complex is wide. And then with QT interval, it slightly differs between men and women. So in women, it is normally a bit more larger. So the normal range is up to 0.46 seconds, and in men is up to 0.44. But because if you think about it, when your heart rate changes, the QT interval can change slightly according to the heart rate. If you're really tachycardic, it means your heart has to repolarize quicker than someone who's got a normal heart rate. And so there's something called the Bassett equation for a corrected QT. So just because you're tachycardic doesn't mean that you have a problem with your QT interval. So the Bassett equation is basically what you count as the actual QT shown under ECG divided by the square root of respiratory rate. I don't know why, how it works, but I just know that there's a equation for the corrected QT interval. So if you want to be a bit clever in your presentation, you can always present the actual QT as shown on ECG and say, you know, you would like to correct it using the Bassett equation to make sure that the QT interval is okay. So that's all I'm gonna say about those two. And okay, so basically I've got 10 ECGs prepared, and I'm gonna ask questions based on the ECG, and I want you to all just put your answers in the chat, okay? So with this one, can people just type in what's the heart rate, what's the rhythm, and what's the cardiac axis in the chat? Okay, so 2 people have answered, and yeah, absolutely correct. So if we count between the large squares between R to R interval is roughly 4. So heart rate, anything between 70 to 80, I'll accept. And yes, it is in sinus rhythm. So if you look at the rhythm strip, there's a P wave before every QRS. And because the R to R interval is regular, then is a regular sinus rhythm. And with a normal axis, so you have a positive deflection in lead 1 as well as a positive deflection in AVF. So therefore it's normal axis. And can people just write whether they think this is a normal ECG or not? Okay, I've only got one answer so far. Would anyone else just like to write something? Okay, cool. Yeah, that's right. So this is a normal ECG. It's always, so anything in medicine, you always need to know what the normal is. So it's always good to be able to recognize a normal ECG. Okay, so if we go on to the next one. Okay, so with this one, can anyone just write down anything that you can spot that's abnormal on there? Okay, so I've got two irregular rhythm, and someone has said no P. Yeah, 2 people have said no P wave. Yep, so it's absolutely right. So normally we use the second, so the rhythm strip to assess the rhythm. So yeah, on here you can see first of all the QRX is occurring at an irregular time interval. And then there is really, you can't really see any P waves here whatsoever. So in this case, as we've said before, to calculate the heart rate, you would have to count all of the QRS complex in the bottom leads and then times it by 6. So yeah, so in this case, it's nearly 100 beats per minute. And someone said left axis deviation. Yeah, so I would agree because lead 1 is pointing upwards, and AVF, you've got more deflection downwards. So yeah, I agree. That would be a left axis deviation. Okay, someone asked, why do we use the second strip? So the reason is because P wave, because where the strip, the vector is on that pie chart I've shown you before, P wave is visualized the best in second strip. And because to be able to determine rhythm, we need to see P wave. Therefore, it makes sense to use a lead that can show you P wave the best. Does that make sense? So be the second lead. Yeah, sorry, I'm just to clarify, it's the second lead that's often used as the rhythm strip, but it usually appears at the bottom of the ECG recording. Okay, so yeah, so essentially, like we said earlier, irregular rhythm essentially is the same as ventricular fibrillation, and this is what this ECG is shows. So now I'm just gonna go through a bit of some more background on AF and how you would treat. So this is just the mechanism of AF. So on the left-hand side, you see the normal electrical current signal goes from SA node to both atrium and making them contract. However, in AF, you have a lot of essentially background electrical current that's running in both atria, and some of them will get conducted through the AV node, but some of them just stay within the atria. And the reason why you don't get a P wave is because these random electrical current, the atria just essentially fibrillates. Yeah, so the muscle just twitches but doesn't actually contract properly. And because there's so many different interference goes on, not all of them will conduct through the AV node to the ventricles. That's why you see the QRS complex being irregular in an AF rhythm. So AF can be classified into paroxysmal, persistent, and permanent. So your paroxysmal, usually it can occur in young people, and it can be a normal phenomenon. So usually when you're a bit too stressed, when after drinking alcohol, it will occur, but usually paroxysmal is self-limiting. You don't need to seek medical help for that. Persistent usually lasts beyond 7 days, and permanent is a AF rhythm that does not revert back to normal. So for the last two, you normally need to seek some medical help. And as you remember, AF is a risk factor for clots and strokes. That's why it's important to seek medical help when you have a AF that doesn't revert back to normal rhythm easily. So risk factors, so any arrhythmia, really risk factors, so it can just include any underlying heart diseases. So that include ischemia, hypertension as well, even though that's a vascular risk factor. And then any problems with the valves can also contribute to abnormal rhythms. And non-vascular wise, you've got your hyperthyroidism. So if you have too much thyroxine, that will make you go into AF, as well as tachycardia. And then exposure to stimulants, so such as caffeine and cocaine, and also usually lung and hearts goes hand in hand. So if you have COPD and there's a backlog pressure going back to your heart, that can contribute to you going into AF. Yeah, so presentation wise, you get like all the usual things: palpitation, breathlessness, and if it's severe, you can get chest pain and also loss of consciousness and dizziness. And sign, really, when you feel for the pulse, you'll just feel a irregular pulse, but you always need to confirm that with the ECG before you can confidently diagnose that it is AF, because they could have a case where they're in an irregular sinus rhythm where you have the P waves present. So the only way to really know that someone is in AF is to do an ECG. And just management wise, very briefly, so when you're in AF, there's two scenarios, two pathways essentially that can occur. So the patient can be hemodynamically unstable. So that means when they're not maintaining their blood pressure, when they are extremely tachycardia and short of breath. So that means their organs are not being perfused properly, and they risk end organ damage. So that's when you're in a medical emergency and you need to cardiovert them immediately. Essentially, you just hook them on some electrodes and shock their hearts when and time, you need to shock them when they are at the time of ventricular depolarization, so at the same time as the QRS wave, QRS complex is occurring, to be able to reset the rhythm. So that's what you would do. But if say an elderly person with a lot of comorbidities has been AF for a month and they are not having any risk of end organ damage, essentially they're hemodynamically stable, you need to work out their score of their CHAS-VASc, and if you remember, essentially that's a score for AF for the risk of a stroke and for your coagulation risk. So if you have a score of 2 or more, you need to anticoagulate them. Normally, with a DOAC such as apixaban or warfarin for a period of 4 to 6 weeks before you can bring them back to the clinic and cardiovert them back to normal rhythm. But if someone is in permanent AF, so it can occur where you cardiovert them, they go back to normal rhythm only for a few minutes and then they revert back to AF. There's not much point getting them back to normal sinus rhythm. In that case, you would just keep anticoagulate them, and if their heart rate is high, control their heart rate with possibly a beta blocker and just leave them be and just keep monitoring them. Okay, any questions on AF at all? Okay, nothing then. So if we move on, okay, so again, same thing. If you can just write down what do you think the abnormality in this is. Okay, someone's asked, if beta blocker is contraindicated, what would you give instead? Yeah, so beta blocker, so it can be contraindicated in asthma or in severe heart failure. So you would give a calcium channel blocker instead. So usually nifedipine, that's what they would give. Okay. Okay. If there's any more questions, just put it in the chat and I will answer as we go along. So yeah, so if guys, you just start writing down what the abnormality you think in this one is. Okay, so some people's opted for ST elevation and some people's opted for left axis deviation. So yeah, both correct. But I would say the more obvious abnormality is ST elevation, but saying that it's got left axis deviation is also correct. But obviously ST elevation is the medical emergency here. So you need to treat that promptly. So somebody just said can't work out heart rate. Yeah, I admit, so this rhythm strip is not the best, but if you calculate, so I've had a count, so it's roughly about 4 large squares between each QRS complex, and it is regular. So yeah, heart rate of 72, yeah, would be correct. So yeah, 300 divided by 4 would be 75. So which lead should we look at for ST elevation? Okay, so this is what I'm gonna come on to. So when you systematically present a ECG, you have to look at every leads for ST elevation or ST depression. So essentially ST abnormalities, you look at every leads before you answer that question. So if you look at the leads here, V1 to V4 has got obvious ST elevation, and I would even argue V5 lead 1 and lead AVL also has slight ST elevation. Okay, so essentially what you see is after the QRS finishes, that point where the QRS finishes before the ST elevation is called the J point. If the J point is usually about 1 to 2 millimeter elevated from the isoelectric line, that's when you would say, yes, there is an ST elevation. And yeah, so in this one, V1 to V4 is very obvious. V5 lead 1 and AVL is not so obvious. That's why when you present it, you need to look at it very carefully. And okay, so that's what it is. So essentially it's a STEMI, okay? So ST elevated myocardial infarction. And we're just gonna go through essentially acute coronary syndrome in the next, oh, sorry, we've got another ECG. So we're gonna go through acute coronary syndrome in the next slide, but people just put down what you think is wrong in this one. So someone's put ST depression. Would it be all right if you write in which lead you can see that? Okay, so let's go through this together. Okay, so yeah, so I've got two answers, sinus tachycardia and also ST depression. Yeah, so absolutely sinus tachycardia. So there's about 2 squares between each QRS complex. So the 300 divided by 2 is about 150. And the most obvious abnormality otherwise is ST depression. So I can see ST depression in, so 2, 3, 4, 5, 6, and 1. Yeah, so that's all the leads where I can see it. So when you see ST depression, so ST segment abnormality in one lead, it's very important to go through the other leads and say it all in one go. So don't miss out any leads where you there is an ST abnormality. So there we go. So this is ST depression, and now we're just going to go through acute coronary syndrome quickly. So essentially, this is just a spectrum of diseases. You can have your unstable angina, which you get chest pain when you're at rest. So your stable angina is chest pain on exertion and gets better as soon as you take rest. But unstable angina, it just happens at rest. And this is when yeah, you really risk a myocardial infarction. And your non-STEMI, essentially you see ST depression on ECG, and your STEMI, you see ST elevation. So how you differentiate the three, essentially you do ECG and troponin for anyone who comes into hospital with chest pain. In your unstable angina, the ECG can still be normal, and they would have a negative troponin, so it's not elevated. And your non-STEMI and STEMI, that essentially tells you what you're going to see on the ECG. And troponin wise, STEMI is very elevated, and non-STEMI can be negative if you present early, but if you leave it later on, it will become elevated. And okay, so that's acute coronary syndrome. if anyone wants me to go through the management of STEMI, just write the question, but otherwise I'm gonna just carry on. If anyone wants me to go through that, we can do at the end. Okay, so same format. If you just note down what you think is wrong with this ECG. Okay, no one's answering. If you don't know, just put that you don't know so I can go through it in more detail. Okay, fine. Yeah, so someone think there might be ST elevation in V2, 3, and 5. So this goes back to what I talked about with regards to the J point. So if you look at the QRS complex in V2, 3, and 5, the QRS actually ends at the isoelectric line, and then the P wave happens. So if you compare this to the ST elevation we saw earlier, so when they send out the slide, you can do that yourself. You can actually see the ST segment is not elevated. And essentially what this is your first degree heart block. So we talked about the importance of knowing the normal range of your PR interval at the beginning. So if you specifically look at leads 2 and 3, the P wave is definitely more than 5 small squares away from the start of QRS. So essentially, this is your first degree heart block because the PR interval is prolonged. Okay, so we're going to talk about all the heart blocks in a bit because I understand it can be a difficult topic. But yeah, just look very carefully at the PR interval in lead 2, and just put yes to tell me to see that, to tell me that you can see that is prolonged. Okay, cool. All right, so this is your first degree heart block. It kind of gives the rest of the ECG in this section away, but then just again, try your best to answer the next few because we got a few more coming up before we talk about heart blocks. So yeah, just try this one as well, and then try to describe what's going on. So, oh, sorry, that gives it away. But essentially, because we're talking about heart blocks, for any heart blocks, it's important to look at the PR interval. Okay, so in all of the limb leads, so leads 1, 2, and 3. So if you look at the PR interval consecutively, I think like you can see it gradually getting prolonged. and until it drops a beat. Is the QRS complex abnormally tall? Yeah, so it is quite tall. So that's I think you get taught in your DPD course about ventricular hypertrophy, but this is not why I put the ECG here. But essentially, yes, in the chest lead, the QRS complex is all quite tall, and it's got quite a large R wave in V1 and also V6. So that can indicate ventricular hypertrophy. But essentially, back to heart blocks, yeah, if you look at the PR interval in leads 1, 2, and 3, you can see the PR interval starts off normal in the first complex, and then it gradually gets prolonged, and then suddenly it drops a beat. So this is your second degree heart block, also known as Mobis type 1 or Wenckebach phenomenon. Okay, so we're going through 2 more before we talk about heart blocks. So again, just look at the relation of P wave and QRS complex in this one, and just write down what you can see. So a hint would be there's a large gap between 2 of the QRS. Yeah, so someone's answered Mobis type 2, that's correct. Would you be able to write down which type? The previous one was type 1, so which type do you think this one is? Yeah, so this is your Mobis type 2 blocks. So essentially, again, if you look at limb leads 1, 2, and 3, the PR interval is actually normal. And then there's one P wave followed by QRS, then another one followed by QRS, and then another P wave, but there's no QRS. So suddenly the conduction gets blocked and doesn't go through, so the ventricles doesn't contract. So in this one, yeah, you can see for every 2 to 3 heartbeat, 2 to 3 QRS complex, there's one missing after. So this is your Mobis type 2. And it's important to know that in Mobis type 2, the PR interval is actually normal, but the main abnormality is that not every P wave conducts through to QRX. Okay, so last heart block. What type of heart block is this? Yeah, so this is your complete heart block. Essentially, that's when there isn't any relationship between the P wave and the QRS complex. And I think another thing to know about complete heart block is that because the atrium and the ventricles are beating on their own, the ventricles are therefore the ventricles are generating their own rhythms. So the normal natural rhythms of the ventricles is very slow, and as you can see, it's very wide apart, and there's probably about 10 large squares between them. So it's about so the ventricles are beating at 30 beats per minute. So usually when you see, and also the ventricles are wide complex as well, and so usually when you see extreme bradycardia as well as the wide complex QRS with random P waves, you can be pretty confident that is a complete heart block. Okay, so now we're just gonna talk a bit about the different types of heart blocks. So essentially the definition is the transmission of electrical impulse from the atria to the ventricles is abnormally delayed at the AV nodes and sometimes doesn't conduct through. And several etiologies, and it's always good to group the etiologies with a heading, so you can have cardiac, inflammatory, infectious, and also medication can cause heart blocks as well. Yeah, so like I said, any underlying cardiac disease can cause any abnormal rhythms, and inflammatory and infection again is can cause a lot of things, and in this case can also cause heart blocks. And presentation wise, so you can be completely asymptomatic in so for example Mobis first degree heart block or Mobis type 1, but as you get to Mobis type 2 and complete heart block, you'll get symptomatic, and the symptoms are usually shortness of breath, fatigue, and especially in complete heart block, because the cardiac output is not adequate, you can get syncope and something called the Adams-Stokes attack. So essentially that's when someone is all right doing their things about, and then you see they suddenly just collapse to the floor with their face turning completely white, and then they'll recover in a while and then completely fine. Even though they might be completely fine after, but it's because the lack of cardiac output that has caused the syncope is a very dangerous sign, and means that they need to be treated very urgently. So in terms of the management of the heart blocks, like I said, the top two, so first degree heart block and Mobis type 1, are usually benign and no treatment is needed. However, if you get symptoms, for example, a reversible cause, such as a medication could be causing them, then obviously you just change the medication. But otherwise, you just monitor the patient regularly in a cardiac clinic, and you don't need to do anything. But if ever you find Mobis type 2 or complete heart block on their ECG, means that they require urgent permanent pacing, because there's a risk that their heart will go into cardiac arrest or a cardiac arrest rhythm. So you need to urgently put a pacemaker in them. So that's about heart blocks. We've only got 2 ECGs left. So again, just put down what you think this rhythm is. Okay, so quite a few people have said ventricular fibrillation. Does everyone think that, or is there any different answers? Okay, so we've got 2 answers. So some people think it's ventricular fibrillation, some people think it's ventricular tachycardia. All right, so the correct answer in this case is actually ventricular tachycardia. So how to differentiate the two? Ventricular tachycardia is pretty regular, broad, complex rhythm. So you see, so all of these are QRS complexes, and they're broad, and you can see the morphology of them is pretty regular. But with ventricular fibrillation, you don't really see any distinctive QRS complexes. You just see sort of random squiggly line on a ECG paper, and it's irregular. So I guess you can use irregular versus regular to differentiate the two, but essentially they're both cardiac arrest rhythms, and which is what we're gonna I'll talk a bit about ventricular tachycardia, and then I'll talk about the 4 types of cardiac arrest rhythms that's a medical emergency. Okay, so like I said, ventricular tachycardia is fast abnormal heart rate that starts within the ventricle itself. So any rhythm that originates within the ventricle itself will give you a broad complex QRS. So for example, we talked about complete heart block. The QRS, the ventricular beat is originated within the ventricles because there's no relation to the atrial contraction. That gives you a broad complex QRS. And also in this case, ventricular tachycardia, the SA node is not involved at the beat. The rhythm is completely originated within the ventricles itself. So again, this gives you a broad complex QRS. And this is life-threatening when it happens. So it's because the ventricles are beating so fast, it doesn't have time to relax. Therefore, you don't get filling of the ventricles, and hence you don't get cardiac output, and you're not perfusing your organs. This will cause end organ failure. And risk factors, again, is any underlying cardiac disease. So it's actually a early complication of myocardial infarction if the infarction is large enough, or you don't treat infarction early enough. You can go into VT, and that'd be a very bad prognosis in any MI patient. And treatment wise, so there's two ways to revert the rhythm back to normal. So one of them is a electrical one, which is you can implant a cardiac defibrillator, and the other one is that you can give them IV amiodarone. So now we can talk about the cardiac arrest rhythm. So there's 4 types. So we've already mentioned VF and VT. So yeah, VF is more disorganized, whereas VT, as you saw, is quite organized. And then you can get something called pulseless electrical activity. So essentially in this one, you see a normal ECG trace. So you've got the P wave and QRS wave and T wave, but you can't feel a pulse on the patient. And, you know, normally, like by this time, if they present with PEA, they probably already collapse and unconscious. And the last one is called asystole. Essentially, that's just a flat line of your ECG trace. So if you see any 4 of these rhythms, it means they're in cardiac arrest. And normally, so the 4 possible cardiac rhythms divided into shockable and non-shockable. So normally, if people are in rhythms such as these 4, you would detach the defibrillator, and defibrillator will assess the trace for you, and it will tell you whether it's shockable or non-shockable. So in shockable rhythm, so VF and VT, the defibrillator will just administer a shock, trying to revert the rhythm back to normal. But it will also tell you if the rhythm is non-shockable. So in those cases, because essentially there is no electrical activity conducting through, there's no point shocking the patient. And the only thing you can do in those cases is to do your chest compressions. And then something just very briefly, in terms of the causes of these rhythms. So anyone in cardiac arrest, when it's, say, a young person and you're not expecting them to die, it's very unusual. You always need to know if there's any reversible causes that's caused them to go into cardiac arrest. And I don't know if you've been taught this, but essentially it's called the 4 T's and 4 H's. And so essentially, if you find someone who has cardiac arrest in an unusual circumstance, you would investigate them for all of these causes listed here. And if any of them is found, obviously you do the treatment to reverse any of those single ones. So that's cardiac arrest. Does anyone have any questions at this point before we just do our last ECG? Okay, so no one said anything, so I'm gonna move on. So this is our last ECG. Again, try to write down what you think is going on. So I think a hint I can give you is that it's regular narrow complex, and see if you think the P wave is present. Okay, great. So people have said that there's no P wave present. And also I want you to write down what you think about the heart rate. Yeah, absolutely. So someone said it's tachycardia. So does anyone know what the ECG actually shows? Okay, yeah, someone's answered supraventricular tachycardia, SVT for short. Yeah, so that's great. That's absolutely correct. And essentially, what you get in supraventricular tachycardia is regular narrow complex QRS without P wave. And so let's talk about that. Again, so I think sometimes people find this a bit difficult as well, because supraventricular tachycardia is divided into two subtypes. So you can have your AVRT or your AVNRT. So I've got some diagram just to illustrate the two. So in your AVRT, as you can see, the electrical current goes through the AV node down to the bundle of hairs and go up the Purkinje fibers. Then there's an extra pathway, so that's called the accessory pathway, going from the Purkinje fibers so back to the atrium. So essentially what's happening here is that you've got an electrical current just going around in loops, and it's bypassing the SA node itself, okay, and to go back to the atrium and to stimulate the AV node. So that's why you don't really see the P wave in a SVT, because the SA node is left out. There's something called the Wolff-Parkinson-White syndrome in AVRT. So I'll show you a ECG in a bit just to illustrate that. But essentially, that extra bit of pathway from the Purkinje fibers back to the atrium is called the bundle of Kent, and it will show up as a upward slurring QRS complex. And I've got an example of that ECG in a bit. And then your AVNRT, so this is actually the most common SVT that is much more common than AVRT. Essentially, you've got a bit of an accessory pathway around the node itself. So the accessory pathway re-enters the AV node. So in contrast to AVRT, where the accessory pathway enters the atrium, in AVNRT, it enters the node itself to cause regular depolarization of the ventricles. And then the diagram just shows you can have either clockwise or anti-clockwise in terms of which way the electrical current goes. And if we just go, so yeah, as I mentioned, Wolff-Parkinson-White syndrome, so I've just got an ECG here to show you. So if you look at where the QRS in the red circle. So you can see that the QRS is slightly broad, and the upward stroke is not exactly like the ones we've seen before. It's got, it's slightly slanted. So that's in ECG, that's called a delta wave. And normally when you see this, it suggests that there is a accessory pathway that is, that's indicative of AVRT. So I think that's everything that I wanted to talk about today. I've just got some resources listed. So Life in the Fast Lane is a really good resource, and they've got a lot of example ECGs. And there's a book, I believe the PDF version is available online somewhere, called 150 ECG Problems. And it's just a great way to practice ECG presenting before your OSCE. And I know heart blocks can be quite a difficult topic for people. So I just found a really good article, for in terms of explanation of different kind of heart blocks. And so thanks so much, everyone. I'd really appreciate if you can fill in the feedback, and if you have any question now, feel free to put it in the chat and I'm happy to answer it.